Okay, so this is the continuation of the polytrauma, cervical fracture, critical care station. So difference between spinal shock and neurogenic shock. Uh, Immediate temporary loss of total power, sensation, and reflexes below the level of the injury. Sudden loss of the sympathetic nervous system signals in neurogenic shock. So what happens in both hypotension occurs, bradycardia occurs in both because we lose the sympathetic vasomotor tone and the sympathetic drive to the heart. Bulbocavertus reflex absent in spinal shock and variable in neurogenic shock. Motor flexor paralysis because and in neurogenic shock it is variable. The time is 48 to 72 hours immediate after the SCI spinal cord injury, and mechanism in peripheral neurons become temporarily unresponsive to brain stimuli, and in neurogenic shock, disruption of autonomic pathways, loss of sympathetic tone, and vasodilation. So yes, so both can, like in both, the main cause is the spinal cord injury, but the presentation is different. Why? Which inotropes are used in neurogenic shock? So phenylephrine, hydrochloride, dopamine, and norepinephrine vasopressors. What other investigation will you do? So trauma CT scan, whole body trauma CT scan, MRI for soft tissues, and spinal cord injury, and ABG, arterial blood cases. What do you see in the CT scan here? So we can see here okay, so this is CT scan of the spinal cord, and you can see that it's the dens. This is the dens of the second vertebrae. This is dens of the second vertebrae, and this is the body of the first vertebrae. So this is C1, this is C2, and this is C3. So most probably the C3, right? And in this diagram on the left side, we have the C1, the small, and then we have the dens of C2, C3, C4, C5, C6, and this is C7. So here is C7 injury. Okay, so basically what happens that we have the C3 and C7 cervical spine fracture with possible cord compression. Will give you an ABG interpret this respiratory disease. So they will give us the in which there will be high CO2 and low pH. So this will be respiratory acidosis. What is the cause of? So from this question, you should remember that the arterial blood cases interpretation is also important. You have to practice it as well. So what is the cause of respiratory acidosis? So phrenic nerve injury, and so it will lead to cessation of respiratory movements. What is the management of cervical spine fracture with respiratory complications? So the mainstays of management following acute high cervical spine injury are the tracheostomy and ventilation. And what to do after tracheostomy and ventilation? A decision is made to do fixation of by neurosurgery. What is the one thing you will do before surgery? So we'll take consent from the patient, explaining the procedure and the complications. If patient is comatose, then we'll proceed to OT, taking consent from two consultants. Okay, so first I will take consent from the patient relatives or patient guardians, and if the situation is emergent and the patient is dying, so I will take the patient to OT under the consent of two consultants. And triple immobilization means that by cervical collar, sandbag, and the tape. Okay, so here what will you tell the patient's family? So cervical spinal cord injury are the most severe form of all spinal cord injuries and may affect one or both sides of the body. The higher up in the spine the injury occurs, the more severe the outcome is. the prognosis is very, very bad and worse. This kind of spinal cord injuries are severe enough that potentially can cause death. How many spinal cord syndromes do you know? So I know the central cord syndrome and the injury cord syndrome and Brown-Sequard syndrome and the posterior cord syndrome. So cervical spondylosis or central cord syndrome, so characterized by, okay, so here we have the diameter of the spinal cord, and here is the central cord, and here is the so here we have the spinal cord. So central cord, you should know that anterior is the motor, posterior are the commissure or the sensory. So most probably the central cord syndrome here with hyperextension or hyperflexion, this can occur, characterized by disproportionately greater loss of motor strength in the upper extremities than in the lower extremities. More in the upper extremities than in the lower, and there is a reason behind it, because the upper extremities pathways or the fibers which are supplying the upper extremities are more towards the center as compared to the lower limbs. So central cord syndrome, center will be damaged. In the central cord syndrome, the center is damaged, and that's why upper limb is more affected than the lower limb. Then in the lower extremities with varying degrees of sensory loss. Occurs after a hyperextension injury in a patient with pre-existing cervical canal stenosis. The prognosis for recovery in central cord injuries is somewhat better than with other incomplete injuries due to the more centrally located anterior gray column containing the motor neurons of the upper extremity. So upper extremities fibers are more toward the center as compared to the peripheral lower limbs. So lower limb peripheral, upper limb center. Okay, so anterior cord syndrome is a compression fracture. So as you know that anterior is motor, actually the motor characterized by paraplegia and a bilateral loss of pain and temperature sensation. However, sensation from the intact dorsal column, position, vibration, and deep pressure is preserved, and results from injury to the motor and sensory pathways in the anterior part of the cord mostly occur after cord ischemia. This syndrome has the poorest prognosis in recovery as the incomplete injuries. So this is more. So anterior cord syndrome mainly affect the motors, and this can also because we have to listen. So we have, let's suppose we have this spinal cord, very crazy type of spinal cord, and you should know this, that we have the dorsal column pathways. This is for deep touch, position, vibration, proprioception, proper touch and proprioception. And there are other fibers which cross to the left side, and there are two types: anterolateral pathway. So some fibers goes in the lateral side and some fibers goes in the anterior side. So pain and temperature, so they say that result from injury to a motor and sensory pathway in the anterior part of the cord, mostly cord ischemia, and characterized by paraplegia and bilateral loss of pain and temperature. So pain and temperature goes in the anterior pathway, pain plus temperature, and here we have the crude touch and pressure sensation in the lateral side. So that's why we will say that pain and temperature and some paraplegia, some motor functions. Brown-Sequard is hemisection. So apsilateral, you cut the half of the spinal cord. So since the pain and pressure pathways, they when they enter at this level, so they cross to the opposite side. So that's why always and always the hemisection, when there is a hemisection, so the symptoms will occur on the opposite side. So accelerator motor loss, yes, motor pathways goes up on the same side and then decassate on a upper level. So accelerator motor loss, corticospinal tract, and loss of position sense and dorsal column associated with the contralateral loss of pain and temperature sensation beginning 1 to 2 levels, because they beginning 1 to 2 levels below the level of the injury. Yes, spinothalamic tract result from hemisection of the cord, usually due to penetrating trauma. Some recovery can be achieved. Posterior cord syndrome, so this is hyperextension injury. Same mechanism here with the central cord hyperextension injury. So posterior cord, the dorsal column tracts will be affected. Patient will lose fine touch, proper touch, joint proprioception, vibration, and tactile localization. 2-point discriminations are lost on the same side, because these pathways goes on the same side and then decassate on an upper level. Okay, so this damage, it will be from the same side because they decassate on the upper side. Same here, the dorsal column medial meniscal pathway, and same goes for the corticospinal tracts, the motor pathways or the motor. So they actually come from above and decassate earlier, like this. They decassate up. Same here. So let's suppose they are supplying a muscle here. So if this injury occurs, this same side will be affected. Same here, muscle here, cut, same side will affect. So corticospinal tract and the dorsal column medial meniscal pathway, they have the same side of presentation like in Brown-Sequard syndrome. But the spinothalamic tract, they anterolateral system, they decassate as they 2-3 levels. Like let's suppose they enter the spinal cord at this level, then they goes on the same side for few and then they decassate. Then they decassate. They decassate to the opposite side, and then same from this, they goes a few levels and then they decassate. So if injury occurs here, so they will 2-3 levels below, but on the opposite side will be the effects. So here we move forward. So what are the functional methods of testing measure ascending and descending tracts? So we discussed these already. Clinical assessment of spinal cord tracts. And okay, so what is the cause of respiratory depression in C5 fracture? Because the phrenic nerve roots supplying the diaphragm arise from the spinal cord segments C3, C4, and C5. Patients with acute injury at this level or above may get this node damage. Cervical spinal cord injury often leads to an interruption of the descending bulbospinal respiratory pathways, resulting in respiratory muscle paralysis and or bulbospinal respiratory tracts, and they will cause resulting in respiratory muscle paralysis. A period of spinal shock occurs immediately after traumatic cervical spine cord injury, resulting in flexor paralysis for muscles below the level of the cord injury that can last from a period of 4 weeks or up to 7 months. Why is new research needed to stabilize the spinal column? To stabilize the spinal column or to decompress the cord to prevent secondary damage. What is the prognosis? Patients with a complete spinal cord injury has a less than 5% chance of recovery. If complete paralysis persists at a 72 hours injury, recovery is essentially zero. After discharge, what advice will you give to the patient? Patient will be discharged either home or a rehabilitation facility. Depending upon the level of the safety and independence, neck brace to be worn at all times, physiotherapy, home exercise program, incentive spirometry 4 times daily, TED stocking to be worn most of the time, because spinal cord injury patients are always bedridden, so they can have the events of thromboembolism. So here we have this chart. So corticospinal tract in the anterior and lateral segments of the cord, like some fibers are in the interior and some fibers are on the lateral side. So we say that corticospinal tract anterolateral pathway. So controls motor power on the same side of the body by voluntary muscle contraction or involuntary response to painful stimuli. Spinothalamic tract in the interlateral aspect of the cord. This also interlateral, so transmit pain and temperature sensation from the opposite side of the body by pinprick. Dorsal column, so of in the posterior medial, so it is mostly dorsally or posterior medially aspect of the cord, so carries position sense, proprioception, vibration sense, and some light touch sensation from the same side of the body by position sense in the toes and fingers, or vibration sense using tuning fork. So these are the some methods to test.